Yeah, if you're
Okay,
ready, let's go.
so I guess you're all seeing my first slide here that says ultrasound assisted peripherally inserted central catheter insertion, and it says right arm approach. So that's correct because I'm using this is said to be or considered felt the most difficult, which I disagree with. It just has to be there needs to be a method. It's not the most difficult, but and I find it the most interesting. So I'm using this one to explain the module that I've prepared for training and competence, followed by um, our guideline, which for the right arm we have kind of finalized. Um, some other colleagues are working on the umbilical approach, and the lower limb, I've kind of sorted that already. So yeah, so this teaching module plus the guideline has the common bit initially as well for the rest of the picks from different approaches. But yes, please keep right arm approach in mind. So we know that a point of care ultrasound scan is being done almost for every system. Um, we know that the pneumothorax we keep diagnosing, the hemodynamic assessment, the duct, the function, and what was this? Yeah, the ET position here. You're going to see ET tube coming in a second. There you go. And then this is, I think, a TTN. However, the line placement with the scanner is gaining a lot of traction, has gained a traction. It's being done pretty regularly, many places, although still not established as the current practice. So I'll today talk about uh, the one we put from the upper limbs, so that the approach and the difficulty we face with that. And in the end, we'll talk about the guideline as well, which is inseparable from this teaching module that I've tried to make for somebody who's neonatal, knows how to put a line in, but does not have scanning as a special interest. Um, so the traditional method, understandably, all blind, position confirmed after procedure by the X-ray, often leading to malposition of the line, and then you repeat X-rays and manipulate the baby, which all becomes far more accurate with point of care ultrasound scan with lesser attempts, far fewer complications, and obviously less radiographs and sometimes no radiographs, and less manipulation, and it does impact on avoiding infections. So here is a comparison that's, sorry. So we're just to remind ourselves how appalling the best of the X-ray can be when you compare a line, when you compare seeing a line on a chest X-ray compared to what you see on the ultrasound. So a more dynamic, more current, real-time image with a moving pick in the vessel you're looking for, compared to whatever you're seeing in the X-ray. I don't need to really elaborate how static, how limited the information is on the chest X-ray. But then you have while the chest X-ray is the chest X-ray for POCUS, you have PIC lines coming in from different approaches, from different parts of the body, and the line moves in different vessels. It gets close to the heart from many different anatomical approaches. So whether it's the IVC, as you're seeing here, or it's the aortic catheter, it's the UVC, or this one coming from the right arm. So it needs a practice, it needs training, it needs some competence. So for that, here is a module that I've made, which is inseparable from the guideline, which actually was the purpose of the whole effort that we put in over the years. Um, so I'll take you through the module, and I'm sharing this experience with you for advice, for criticism, and yeah, so any comments will be really enlightening. So this module for training and practice, which will be linked with the guideline, has some sections. The first one, there'll be some, I'll briefly talk about the ultrasound approach for this procedure versus the X-ray. So it's a different mindset. Um, a bit about the equipment. That then section 3 is where I'll put more emphasis and show you loads and loads of videos. And then what you do after you have identified the central line in a vessel, how confirming the tip, and finally assessment of tip migration range and final adjustment. So we'll talk about them as we go through. So the first section, a picture is worth 1,000 words. So you're seeing something completely different from how you do it when you're getting an X-ray. So somebody does a line and then walks away, keeps waiting for an X-ray. So nothing of that sort happens here. So it's a 2% technique where the scan bit, the ultrasound bit, has to be an integrated procedure, integrated into the procedure. It's not measurement dependence. It's about seeing, recognizing structures, to recognizing actual structures rather than saying that this is 2 centimeters away from that. It's not X-ray dependent at all, although currently under some circumstances you may ask for one, but essentially it's not an X-ray dependent thing. The concept of chambers versus vessels. So the vessels, that's where you look for the line and make your adjustments. If the line is in a chamber, the right atrium, in our case here, you don't measure, start to chase, or try to find where exactly is the line inside a chamber. So essentially, it's the vessel where you're going to look for it, and we'll see how. The disadvantages are actually not exactly disadvantages. If our patient is smaller, then our area that we are looking for the line is also small, and the relative size of the vessel versus the line is is an advantage rather than a disadvantage. But then yes, you need some competence and you need to know how to do it. Um, I'm going to jump beyond this. You need to know your weapon, yeah, all the keys in your machine, what it's equipped with. And it's strange that the machines I noted are a lot better than most neonatologists would actually know. They know a few buttons, but we never really sit down and see what the machine offers. So know your weapon. Uh, okay, so in section 3, we're going to talk about identifying the pick inside the superior vena cava. So I'll take you through what anatomical landmarks I would want a trainee or a colleague who's developing this skill to look at. Then identifying the aorta. So that's going to be the key, the central point of uh, my advice for people who are starting this, because aorta is the big vessel, is big pulsating structure, which is relatively easy to find for somebody for whom scanning is not a special interest field, compared to venous structures where the pulsation, the veins where the pulsation and the flow is not as aggressive as it is in the aorta. So start with the identifying aorta, and then we will talk about how to move to SVC from that view, and then identifying the pick in the body in the vessel. So I would say to somebody who's reading this that generally this yellow bit here is the area. So this essentially is a hands-on thing. So rather than saying this is the intercostal space, I would say that that's generally the area where you're going to look for aorta, subcostal margin, sternum, the suprasternal area, but the yellow bit, just to keep in mind as a rough guide where the probe is going. So that's one position. That's another with a twisted probe, which we'll compare when I'll show you the videos. And making twisting the probe around. So now the person who's using this module grabs the probe is on the chest, and where the yellow area was, tries to find something like this. So any bit of the ascending arch, descending abdominal aorta would suffice. But yeah, so this sort of thing, and it shouldn't be terribly difficult. And that's another one because some people like colors. So it's just the same. It's another patient, another example, but with Dopplers on. So I think it helps people. I've noted that my colleagues say the more examples the better they feel. So that's another patient. So that's how the aorta would appear. And here is so before this person sweeps to the right side, needs to understand that here is this uh, diagram of the aorta, where there is this the superior vena cava shown next to it, which never appears, which is a diagram, and it doesn't happen in an ultrasound. So that's the structure here. Oh gosh, technology. Uh, and this one is has Doppler in it. So we are chasing this vessel here by sweeping to the right. So this clip shows the aorta, which I would hope that after having seen so many examples, the trainee or colleague would recognize the aorta here, and then the sweep towards the right side to see the superior vena cava here. So that's the atrium and the SVC popping up. So without the sweeps, that is what this person is looking for. So that this whole structure easily visible is the SVC with a bit of flow visible here as well, and the atriocaval junction. And then so these are the two together. I understand this is the left brachiocephalic here, but just to make a newbie understand the arch, they're close by, and it's a correct way of angling the probe to find the SVC. So then once you're on to the SVC, identify different structures. So I'll bring it back here so that you can see the the structures I've written on. So right atrium would be here when it runs, the superior vena cava itself, the azygous vein, and then that bit of SVC that comes in, that is formed by the right and the left brachiocephalic. So you cannot see the left one more than a protuberance that comes off the junction of the two. The more vertical is the right. The left one swings around and goes to the left. It goes out of the plane, so you can just see its origin bit here, and that's all. So I'll run this, and so the right atrium, the junction, uh, and this bit here is the left atrium and a bit of pulmonary here. So identify all the structures. This is the azygous, and that is going to us. So this one is the right, and this protuberance here would go out of the plane and not be visible, but is going to the left side. So to see the SVC, in order to make sure that you're not missing the line because you didn't see, you were seeing the vessel in a certain angle, I would recommend 4 different views. And it doesn't take very long. It's just the right kind of uh, angle and twist of the probe and sliding it slightly up and up, down the chest. So when you're relatively higher up the chest, you could see obviously the more distal part of the SVC where it's being formed by the two. So you can see here the protuberance I was talking about, the left denominator coming off, or should I say coming in. And in my handmade diagram, that's what I'm trying to point at. And this bit is the right denominator. So this is basically the junction. So you're seeing the right brachiocephalic, which is more vertical, and you can see a bit of PIC line peeping in into the junction as well. So you're still a little bit high, and you get a better view of this bit uh, on the relatively high on the chest. Then as you slide it down, okay, I don't know why this is not running, but yeah, so that's left atrium, right atrium, the SVC itself. So now the probe is a little bit uh, towards the mid sternum, and a bit more vertical as well. So here, pulmonary, left atrium, right atrium is somewhere here, and you're seeing. So now the distal bit is relatively less in focus, and you're kind of chasing the tip towards the cavoatrial junction. So that's the second view. The third is a modified one. So if you see here, uh, so you're seeing the valve and the right ventricle here. That's where the superior vena cava is, and you can see the line sitting here. By the way, you cannot see the IVC, so that's why it's not a bicaval. And this is the left atrium here. So it's a bit skewed view, not bicaval, and at the same time it's not short axis either. So if you see here in the mid is the aortic valve, aortic, not the pulmonary, and the pulmonary artery is somewhere here. And in this skewed view, the line in the SVC would superimpose the rest of the structure, and you can really see the tip pretty accurately on how far has it gone near the into the atrium or close to the junction. So that's so I made this diagram here. So you will not see the IVC, you will not see the pulmonary artery, but it's something in between uh, that gives you a very accurate placement of the tip when you really need to see um, uh, whether you have missed something on the high up the chest views. There is another view here, which I would recommend seeing. So you can see, so this is the bicaval, and this is a bit subcostal as well. Now you can see that there is a good 2.5, 3 centimeters of superior vena cava visible here. This is a pretty long junk, so I keep measuring it. It's at least 2 centimeters from here to here. It's a decent distance, but I never found this that makes things very obvious. But because it gives a great view of the SPC, so I thought I'll just bring it up and see what the audience has to say about this. So that's so these are so all the views summarized here. So this one and this one, they're the same with and without Doppler. And this was an actual line which looks beautifully placed here, right? But it wasn't. As I went down the sternum, the tip actually turned out to be farther in. And if you see here in the modified view, it's quite close to the junction. So that's why it's important that we see it on all from all angles, not all angles, but slightly different positions. So that's another baby, but it is just to show that as you go down the sternum, the junction, other structures, they become more visible compared to the more distal one, and that's the bicaval. So so that's what you do to identify the SVC, and then how do you determine the side? Don't determine the side of where the from where the line has come in, whether it's right or left, by scanning. It's absolutely mandatory to have clinical information, which I'll mention when I explain my guideline here. So you should know before starting by looking at it and by talking to your colleague which side the line is coming in. So rely on the clinical information. However, for chasing and for exploring, you need to know how to do it. So that's why we should know how to do it. So the right brachiocephalic, as I mentioned, beyond this end/origin of the left brachiocephalic, if you go more vertical, that'll be the right one. And the probe position would be something like this. Maybe not this high, but that's the orientation, more vertical. And I'm going to run this. So you can see the line coming from the right brachiocephalic, whereas the left here is empty, but it's very nicely visible. And this one again is the, yeah, so that also, I'm using this example to say that again you can see the junction here, but it's coming from the right, so you can tell that it's coming from the right. But again, it's the clinical information that matters. Yeah, it's the same one with Doppler in the left one. So we see the proposition. Now we are almost completely vertical and pointing towards the left shoulder, and this kind of S-shaped structure is the left brachiocephalic. Yeah, and that's the junction. So with the probe in a more horizontal orientation, this is no more the left one. This is the right one, and that's the left. And yeah, so that's come on. So you can see the PIC line sitting in the, so this S-shaped structure here, this is with or without the Doppler, and there's a double lumen PIC sitting in the, and I don't want to run it because it just disappears. Yeah, you can. So that's the left side. I'll move on. And here, identify the junction here. And I'll run it, and you will have a second to see that it's actually coming from here, not there. So it's coming from the left. So mind the junction. There are two. So one was this, where the right is this one, and sorry, the left one is this one, and the right is this, and you can see the pick coming in from the right side. And here the difference is your probe is more vertical-ish, and the probe is horizontal, pointing towards the left. Your left brachiocephalic will open up, and the junction now the left is on the left and the right is on the right. Whereas here it's this is incorrectly labeled, so this is left and right. So once you have identified the SVC and both the brachiocephalics, um, by that time you'll be able to see the body, some part of the PIC in the vessel. So then comes the question of which is the tip. That you're going to finalize by moving it. And there are small movements in and out. And so you would be, so here, so this is the inferior vena cava. So what it shows here is the tip or PIC inside. It's just seen. I would describe this as the PIC entering the heart. I would not say where it is. I would just say it's gone in. So as I said, chamber versus vessel. So I won't chase, comment, or worry about how far this really is. And here it shows being pulled back, and the movement has now told you where the tip is. So I'll show you how it, or I'll show the more novice people, more beginners, how it appears when the tip moves. So you would just see the tip, how far is it going back, and decide where you want to stop it, and accept the tip location as an acceptable position, rather than trying to measure what's inside the heart and trying and sweat and worry and it'll be completely it's a waste of time. So you don't do anything in the chamber itself. So let's say you pull the line back by 1 centimeters, and you still see it here. So you don't have to say, I'm going to pull 1 centimeter, 2 or 3. You just slowly keep pulling until you start seeing the end of the line. And so this is before and after. So let me show you how it feels to your eye when there's a tip movement. And I understand this. I just to remind you that this is for somebody who's relatively less experienced and kind of learning. So, but sharing with you, here is how the tip would appear moving. So here's the tip of the same line, and you can see it moving back. So it's running again and again. You can see the tip moving back, and again if you're pulling it back slowly, you can actually see it moving back. So it doesn't have to be before and after uh, uh, picture. The video, a real-time video, does show where the tip is as the tip moves. Another example. So you're seeing the tip here, which by moving I decided that okay, this is the last bit of the tip, and then you're seeing this climbing, being pushed in. So it goes in and in. It's somewhere here. It doesn't matter how much in, but it's gone into the heart in an unacceptable position. So I would, without measuring, I would just pull it back. You can see the tip crawling back, and then it's the operator's choice where you want to stop, and from and where do you want to stop uh, is where we move on to the next section, which says assess the migration range. So there is this big debate about which position you should x-ray the arm or leg in. Is it adducted or 90 degrees or whatever? I think we found a solution here. So the migration range is matters. So here I'm going to show you so you see my hand holding this little leg here, and so I would just extend the leg fully and flex the leg fully, full range. It doesn't have to be in the middle, and see what it does. And what it does um, is so the small screen you can see is the video is here. So you can see the tip here. So when the leg was flexed, you see it suddenly gets pushed in, and then uh, um, I've asked the colleague to extend the leg, and it came out. It moved out a little bit. So now, so at that stage, I knew that full range of movement would do what to tip position, and then I would decide that okay, if I leave it here, for example, with full flexion, it's going to go in. So I would leave it here. So without doing this migration assessment, if the tip is here, you may buy it as a good as an acceptable position, but after the migration assessment with the movement, I knew that leaving it here is safe for this particular moment, but not when the limb will move. So for this, I was able to choose the a safer, more appropriate final tip position. So once we've gone through the training module, now the guideline will make sense. So again, as I said, one picture is worth 1,000 words. So this the delegation of jobs, the scanner and the operator, and you've seen this video already. So it has to be planned as an integrated procedure, the scanner and the insert together, unlike the X-ray thingy. So you can you can see here that I have the probe and the leg both in my hands, whereas here the person who has the lower limb is a different person, not me. So it can be done both ways, but it depends on how much you have experienced this and how much you've practiced on this. But this is possible, very convenient as well. But it's your decision. So the scanner has certain responsibilities. Makes the scanner ready, uh, positions the scanner. This is an important issue, that where you position the scanner and how you let the nurse uh, access the baby during the procedure. So scanner's position, the machine's position, and then absolutely mandatory is to discuss and acquire clinical information, that which limb are you going in, which side, how much depth are you expecting for the tip to go in, what is the size and type of the pick. So for example, if you're putting a one with a guide wire in, it's I think it's a better idea to scan before taking the guide wire out, and then intended depth of insertion, of course. So all the everything that the operator colleague knows must be known by the scanning person. So the insertion bit goes as per unit protocols. So once the operator feels the pick has reached the measured depth, then invites the scanning colleague, and then together they communicate to each other this by moving. So first the movement test, then the migration assessment test, and the two together decide where they wish to leave the tip, and take a good look and documentation of the insertion depths visible at the site of insertion. And my guideline will have links to relevant sections, so that people can revise and see the image moving rather than just reading a PDF. And then, uh, yeah, so I've just spoken this already. These are steps which now should be very easily understandable, not requiring explanations. So, troubleshooting. So, a word about troubleshooting. To me, troubleshooting is not when your line is stuck in the knee or at the shoulder, because we were talking about the upper limb. So if it's stuck somewhere in the pelvis, in the shoulder, that is not some kind of that is not an occasion for ultrasound to come in and troubleshoot. That's not that it's if it's stuck, you do what you do. You don't scan, or you don't even do an X-ray to see where it's stuck in the knee or the elbow or the shoulder. So that's to me, troubleshooting is uh, when um, you're when uh, the line has gone into the neck. So you scan the SVC, you don't find it, and you angle the beam up towards the right brachiocephalic, and you find that it has gone up here, and there is a corresponding X-ray here. You can see this line going up, and in this moving image, you can see the cervical spine, the line here, and you can see the lung apices. So it tells you, so spine, lung apices, and superior to that, it's gone up. So troubleshooting, to my understanding and my recommendation, is that this is where troubleshooting comes in. The trouble is not that it's stuck in the shoulder. It's not going beyond. You're going to throw it away anyway, whatever you do. If it's not going beyond this, that's not trouble. The decision making is different there. The trouble is this, that it's in the neck, and that's where the scanner really is a great help. You can watch it being pulled out, and then in different neck and shoulder position, you can push it back in and watch it going in. Um, so that is troubleshooting, which only the ultrasound can do. And a similar troubleshooting occasion is when, if you see the line here, it has gone from the left, so you're approaching right arm, but it's gone across to the left brachiocephalic. And you can see so see the S-shaped structure here, which was the left brachiocephalic. Sorry, yeah, okay, I'll not run it because it just disappears. So you can see this coming from this side. It's not the side actually, but so this structure is the left brachiocephalic, and it was meant, and the junction is here, so it's coming across. So here again, if you're trying your luck, first of all, I know some of you might say that the left brachiocephalic is also a big vessel, central vessel, so it's okay if it's here. Some may not. Some would feel better if it's angling towards where it was intended to. But whatever it is, if you pull it back and push it back in with an X-ray, it's a disaster for all the time you'll spend and all the uncertainty and all the blindness. But great troubleshooting uh, with the scanner. And I have recently scanned a line which which would which would waving in and out of SVC into the left brachium. So with the hand movement, so there were two different X-rays, one with the line going across the left brachiocephalic, and one X-ray with the line beautifully positioned in the SVC. So when I scanned and moved the limb, it turned out that it was just it was just moving in and out with the shoulder, the arm movement. So that sort of troubleshooting, especially the neck thing, where the line actually did not get stuck anywhere. The operator colleague intended a certain depth. It nicely went down there. There was no problem pushing it in, but it was in the wrong place. Then again, if you're stuck at the elbow, that's not the ultrasound where you would use an ultrasound. So some of the recommendations, basically questions. So timing for when do you want to repeat an ultrasound to monitor? It's your decision. Criteria for X-ray and uncomplicated procedure. For me, if there's nothing funny happen, I would not. I often don't. I can't remember the last time I had an X-ray. Uh, Need for X-ray when troubleshooting. So again, troubleshooting has a certain meaning. Your line stuck in your armpit is not trouble. That's a stuck line that needs to whatever decision you make on it. If it's not going beyond the armpit, it's a that's not the trouble you shoot with the scanner. Saline test. Uh, I just find this very. It just adds to a lot of work, and it has never added a very clear benefit to finding the tip, because yeah, so I think when the line moves, that is a very solid, that gives you very reliable information of where the end of the line is. uh, and Splitting the procedure kills the idea of saving time in x-rays, uh, so please don't. However, it doesn't mean if somebody calls me in and says, "Can you have a look at the line that was done a day ago?" That's fine. It still helps. But if you're doing a fresh line, I would suggest not splitting the procedure. And yeah, that's all really. Thank you very much for your patient listening. And I would absolutely love your advice, comment, criticism on this.
Hi, I don't know many of you very well. My name's Sarah. I'm in Oxford with Zoltan and Giza and Jean. I found that really interesting because I'm sort of leading their sort of establishment of POCUS here and doing lots of scans, and really interesting to see how you're approaching it. I had a couple of questions because we've created a guideline which we're running. I don't know if that's been shared at all yet. I don't know if, have you seen that or heard of it?
The guideline Giza and Jean are making, is that the one you're referring to?
Yeah, so I helped them complete it, and then we've actually had it ratified. So we actually have a guideline in use on our unit now, which I'm helping them implement, and with a view to starting to train up as well. So it's you're obviously a few steps ahead of us, which is great. Some of the things which came up, which is quite interesting, just reviewing your views. So one of the things we talked about was standardizing our view. So I know for some of them you're doing similar views, sometimes from the left, sometimes the right, depending on whether you're using the C310 or a cardiac probe. Obviously, orientation automatically changes. And you made the point about labeling being really important for reviewing, I guess. Oh, are you there? Sorry, I don't know if you're frozen.
So your question is which probes I used? Is that?
Well, I noticed you use both probes. You use a phase array. You also use a a curvilinear. We've also got the short linear hockey stick, but obviously their presets are often to default to different flips, left and right. And so we've tried to standardize that in our views on our protocol, but do you specify, you know, when you're scanning?
For the IVC, when I go subcostal, that's where, and in my guideline for the lower limbs, yes, I use the curved one, the C3 one, because I just found that a little bit more helpful. But the rest of them, they were all the 12S, the cardiac probe.
Okay, so that's quite interesting. And then, like you, the idea of migration, and we've seen quite a lot. It's quite interesting to see. Obviously, not surprising, you're seeing the same thing, that the lines which can look perfectly sat in the SVC, as you're scanning, it can flip into the opposite brachiocephalic vein, particularly on the very small babies. And we had a discussion going, well, is that a problem? If we pulled the line back, is there a risk of it then flipping into another, you know, up to the head, up to the neck? So do you keep it where it is and accept that it's in a main vein? And I don't know what your approach is, because we haven't come to a decision on what to do on these ones which are very mobile, and what the risk of leaving them quite so mobile is.
So the one I showed, the flipping one, we in the end, so yes, there is no hard and fast thing, nothing set in stone yet, but we had a debate and we said that, okay, if it's flipping both the vessels, either it's in SVC or the left brachiocephalic, so both are acceptable. So we were, because wherever it was going, both were acceptable, so we didn't really worry too much about it. But if it's and it does, I haven't seen anybody flipping up into the neck. Yeah, that's what we did. We just accepted it and secured it there.
We've had one baby going from the neck to the brachiocephalic to the SVC and back again, depending on position, which was quite unnerving. Yeah. And then the other thing, you mentioned briefly monitoring. I know it's taking it on a bit step, but that's actually what I'm doing. So I often, on a weekly basis, try and round all of our lines. And it's actually, we've picked up a clot in one line earlier this week, in one brachiocephalic vein associated with the line, which has been in for about 3 weeks. I don't know if you're picking up, because obviously there's the implication of doing routine scans for migration, but also for other problems like clots, you know, that has to be integrated into the protocol of what do you do when you find one, and or you know, what's the significance, etc.
Well, that's a great point. We can consider putting this as well. I tend to, my unit, we tend to scan the lines with an effort to couple scanning. So if the baby is due for some other scan, I would just because I'm a big believer of using the probe with dexterity. So you go in, don't just do one thing. So I would have a look at the ET2 position, the line as well, and do the head scan as well. So that's why I tend to, instead of saying that, okay, day 3, I'm going to do it, I would say, okay, if the head scan is due tomorrow, I'll have a look at the line also. But thank you very much. That's a good point, that for anything gone wrong, the troubleshooting bit can have, or complication bit can be added in for this also.
Thank you. Really interesting. Really interesting to hear what you're doing. Sorry, I don't know if anybody else got comments.
Sorry.
Hi, can I come in? Hi, I'm Ejin Matu, I'm one of the consultants from Evelina. Yeah, very interesting talk, very interesting to share our experiences. I would have 2 questions. One is, do you do for all the lines the X-ray as well? Because I think, yeah, we've started this probably 5 years back, and I think we have in the guidelines that we have to do an X-ray as well. It's just to make sure that the line is not flipping at some point and it's actually deeper, as you've showed in your examples. We also implemented glue recently, so migration-wise, we wouldn't have any complications, because let's say someone hasn't secured the line as well as we could have. So I think the first question is about the X-ray. The second one is, how do you decide where you leave the tip? I can tell you from our experience, we always put, as you showed in your videos, with flexed legs, and also we do the movements, the arm to the 90 degrees and even higher. But when we do the X-ray, we always do with the leg flex and also with the arm at 90 degrees. But unfortunately, with that, we have noticed that depends on the basilic or the cephalic, the line will be either sometimes too long or too short. And we had recently a situation when the line was X-rayed at 90 degrees with the arm at 90 degrees, right arm at 90 degrees. And then a few days later, we found that line dangerously low in the heart, like 2 centimeters had to be pulled back because actually the line was in basilic. So do you have a strategy, depending on where the line is, how you do the X-ray, and is that variable, or is just you do all the X-ray in the same position of the arm as we do?
So question number one, the X-ray. So in my unit, I'm lucky enough that my colleagues have agreed to a rather simplistic, but I think it's quite a reliable criteria. I just show the after I'm finished, I keep the nursing team involved. So I would ask the nursing person, whoever looking after baby, who has nothing to do with scanning, and I would say, can you see this line tip? And if that novice person, the nurse says, yeah, okay, that's very clearly visible to me. So I use this as a criteria for not asking for an X-ray. If I feel people are, it's something I'm showing them which they have to use a little bit of imagination, then even if I'm happy, I would get an X-ray done for all the right reasons, for all the legal reasons. And my number of X-rays I can't remember the last time I had an X-ray done for a line. I think it's more with better machines now, with a bit of technological advancement, you get very good images. So yes, for the last many years, many months, sorry, not years, many months, I don't have corresponding X-rays. The X-rays that I showed, they were lines put in by somebody else, had an X-ray done, or somebody demanded it when I wasn't the on-call consultant. So that's my answer to the question one, is that if it's very obvious, then and the idea of why I should ask the nurse is because it came from them. That after all the talk about the advantage, you do your scan, you finished, and the nurse said, do we still need an X-ray? So I thought, okay, that can be a criteria for me, that if everybody just feels, I mean, the relevant people, they feel you don't need an X-ray. Why are we doing an X-ray now when we can see it? So that's where it came from. I had a discussion with the rest of the team here, and for many months, no X-rays. Unless, and the only reason I would do an X-ray is when it wasn't on my shoulder, somebody else was feeling anxious. Or the other question is regarding what position for an X-ray, the limb position. So I've really talked hard on this with everybody I knew. Nobody really knows where the arm or the leg should be for an X-ray, and it's not very practical either. It's really difficult to tell people where to standardize this. There is no evidence that 190 degrees or full adduction, which is the best. There's no evidence on this. And then even if you choose a position, it's not very practical to convey this to teams. You may not be around, different teams coming in going. So I'm not focusing and spending my time on how to get an X-ray done. I'm spending my time on scanning it, and then it's really it was more than what I expected, that the movement really moves the tip by centimeters, like you said, 2 centimeters. So that's a big distance for a preemie, 2.5 centimeters. So it has been really useful that I would just move the limb in a full range of motion, as far as the baby's leg or arm can be moved during cares and nappy changes, and see how much does the tip go in or out, and according to that, then choose a appropriate position, and that has worked very well. I can't remember a line in many months that somebody later found poking into the heart.
Yeah, thank you for your answers. Yeah, I think the movement of the limbs, it really remains a challenge, and because we've seen the opposite situation, when you look at the range of movement and you can see what is the deepest, but then it can happen that actually it looks too short on the random X-ray, that it's been done for, let's say, a chest X-ray. And I think it's not about, yeah, I understand that you've got extensive experience. The problem is about the whole team and how they feel comfortable with what 1 or 2 or 3 people are doing. So I think it's about thinking of the rest of the team, and so they feel that what they are doing, it's safe. So I think, yeah, thank you for your answer. I think Virginie has put in the chat. Thank you, Virginie. Yes, we did have in the past on why we would advocate for X-rays, why we have advocated in terms of safety for X-rays. We did have situations when the line made a curl and then we could see clearly the tip. So in that situation, only the X-ray would pick up a curl, let's say, in the inguinal fossa. And I think especially after the last central line recommendations from the so I have the BAPM framework recommendation. It does advise to see the entirety of the line. So I think from that point of view, my team would feel more comfortable to be able to assess at least once the entirety of the line.
But I agree. I mean, there's nothing not to agree here. That X-ray is not out. That we are very far from a stage where we'll say, okay, no X-rays. So they can. That's why I'm just saying that if there is an indication that's good, we should get an X-ray done. But I may say in most situations, when the older X-ray practice is just consuming time, you don't really need to do an X-ray because that's an established practice. But yes, there are some indications where I would just go for an X-ray.
Thank you.
May I just ask how many people other than yourself do the POCUS scans? Have you sort of managed to train much of your sort of senior team or your registrars, and how that's going?
Well, independently, 0. But there are quite a few who are able to help. I mean, they, as part of the team with me, with them, then they can do it. They can hold the probe if I'm inserting the line, or even if I'm just standing, then with a little bit of pep talk and some advice, but completely independent, none yet.
Okay, because I suppose that's a challenge we're at now, is looking at how to train, and because for it to be viable as a standard procedure, you need to have 24-hour cover, and obviously that's not being done here. It depends on there's a handful of consultants and a few others who can do it now, which is great, but it's just building up that experience of all. In Evelina, do a lot of you scan? I think you train a lot of your seniors.
So we in Evelina, we do train all our registrars. Obviously, with upper limbs, it takes a while until someone gets confident with scanning. With IVCs, yes, we aim to train all our registrars to be able to assess the tip of the line. But in terms of having all the consultants on board, I think that's a bit difficult. We would probably have around 5, 6 people that would be comfortable, but with output limbs, I think that can be reduced to 2 or 3. So
Yeah.
I think it's quite difficult to reach that critical number, or it's even more difficult to reach that to all the consultant body that we have on the unit.
Yeah, I think that's the biggest challenge. Until, like head scans, everybody's OFA standard, everybody gets them, and it's not a problem. It needs to get to that point of familiarity across the board, I think, for it to be, truly standardized. But yeah, interesting. As I say, that's a challenge, is just to start training up and knowing how far to go. I like the idea of starting with the IVCs, because that's certainly easier, and the SVCs. So yes, we'll keep working on it.
At least one of my colleagues is so POCUS is a pretty wide field. So things are coming up, but then there are too many things to learn. So there's a lot of interest in predicting surfactant administration. So at least one of my colleagues is quite independent and feels very comfortable scanning, deciding on surfactant, and using LMA. But then there are more things than just the line scanner itself has quite a few different approaches and all that. So yes, that will take time, but I can see that it's happening. There is interest, and people understand that this is the way forward.
That's great. I like the idea of using glue to hold your lines. That's quite interesting. In Evelina.
So we started, Sarah, this using this especially because of the long line associated bloodstream infections. So it's more, I think it covers both of actually. So it prevents improper securing of the line in terms of migrating in accidentally, but also at the same time we've noticed a reduction in bloodstream infection associated to central line placement.
Okay, so the idea, but that you've got, while it's still oozing, that potential source of infection from the site of insertion.
Yeah, we've seen sometimes, especially the knee insertion, like softness at the knee side when the baby is moving under the dressing, there is a minimal movement of the line in and out. So that could be potentially mobilizing some bacteria inside intraluminal. But I think once you've sealed off the entry point, I think there are some good articles especially in States. They have started a while ago, and they've demonstrated the reduction in infections.
Eugen, hi, nice to hear your voice. It's Jean.
Yeah. Hi, Jean.
Hi, how are you? So sorry I joined late. I was at another meeting. Really interested to know what type of glue this is, and where exactly you're applying it, and is it suitable for preterm babies?
Yeah, absolutely. So it's something that is on the UK market. It's IV secure line. I can send you a picture.
Oh, that would be great.
Jean. And you can order it straight away, so it's available. I think it's used in adults, but we've used it in 22 weekers.
Wow! And
it's absolutely safe. So if you use a peel to remove it or to adjust it, that's absolutely safe. So and at some point we had a very a preterm with a very bad skin, and because of multiple adjustments of the lines. With the peeling off of the tegaderm, the skin was so raw, we inserted a new line and we've secured it, or even the tegaderm with the glue, and that lasted, and no complications. So we've been using it for a significant time now, and we haven't had any complication related to glue.
That's amazing. So so you have to remove it with a peel. It doesn't disintegrate or anything like that.
To be specific, after 7 days, you don't don't need to change your practice in any way. So it will be normal practice. You don't need to use a pill. If you do any manipulations before 7 days, it's recommended that a pill is used, and that essentially removes it easy.
That's really interesting, and presumably is not licensed in preterm babies yet.
I don't think that someone has licensed specifically for this.
And then did you have to initiate a guideline before you introduced it?
So we had a trial in terms of seeing, in terms of a safety, how it's tolerated first as a skin tolerance on all gestations, and secondly we needed to look whether it affects or not the line itself, and it didn't. And secondly, we had to see when. So initially we started it. That starts from POCUS as well. Sorry, it's just we've hijacked the discussion. So it started with POCUS training of the IVC insertion, not IVC, like it's lower limb insertion with IVC POCUS. And we only used it initially when we were absolutely certain about the line position at the time of insertion. So only with POCUS, we were making that call. We were saying, yeah, we are absolutely happy with the line position, not waiting for an X-ray, obviously, securing with the glue, and essentially watching whether we have we needed to adjust or not. So we only needed to adjust in one case when it looked, and then that loop unfolded. And we can see that on X-ray. And even then, it was easy to adjust with a pill. So we didn't see any complications related to use of the glue.
That's brilliant. That's an amazing innovation. It's great to hear about.
And in terms of it being used in London, I think this experience has been shared across the network. And I think more units from our network are going to implement it. But it's essentially, it doesn't need special training. It's like instructions how to apply the glue, and we started by putting an alert on BadgerNet that should this line needs adjusting, obviously use a pill, because this is not standard practice using a pill. But if you are using a pill as a standard practice for any line dressing, then wouldn't need even that alert.
Yeah. Amazing, thank you.
Eugene, can you just send us the name, the trade name?
Yeah, absolutely.
Thank you, Eugene.
Thank you.
I think I had a few thoughts about clot, but just very quickly with clots, I feel like if there is a thrombus there, it would make sense to get the radiologist to confirm the position, because they're specialists in scans, and if there are any governance issues, then I think they need to be clearly documented. I don't know what you guys think about that.
I mean, once you find something, then make a referral. That's what I'm thinking.
Yeah, I think.
But first, you have to find it. So if you have, if I make it part of the guideline, just like find the problem, and then the radiologist can come in.
Yes. Thank you. I'm going to catch up with the video. Thanks so much.
Okay, so thank you very much for all the lovely comments. I'm definitely going to chase this glue, Eugene, and thank you all again, and see you next week. Jean, you're saying something?
No, that is just me pressing the wrong button. Yeah. Okay. Thank you.
Okay. Thank you, everybody.
Thanks, Ahmad.
Thank you.
Everyone.
Bye.
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 Thank you.